Hi, how are you? I am Dr. Willems with Bucks Developmental Pediatrics. I'm a neurodevelopmental pediatrician in Lower Bucks County. And autism is one of the things that I do see in the office. And I diagnose and treat those patients. And today I'm joined by two providers from Theraplay for an interactive Facebook Live session.
Hi, my name is Courtney Klinger. I'm one of the speech language pathologists at Theraplay, and I'm also one of the directors of outpatient services.
Yep. And hi, my name is Bianca Angstadt. I'm an occupational therapist at the Ben Salem office at Theraplay.
And thank you for joining us today. We will be talking about autism and treatment modalities in celebration of Autism Awareness Month, which is what April is. What I will do now is I will pull up my slides here. Okay, excellent. Hold on one second. And okay, here we go. And what I'll do is I'll just give a general overview about autism, how it's diagnosed and treated. Autism is a developmental disorder. It affects social language and behaviors. The latest prevalence studies show about a 2% prevalence rate. So 1 out of every 54 people are diagnosed with autism. There is a much higher risk in boys than girls. The cause is very complex, and there's not one identified single cause of autism. It's usually an interplay with genetics and some sort of environmental component, most of which has not been identified to date. If one child is diagnosed with autism, siblings are in a much higher risk group of having a diagnosis as well, going from 2% to now 15 to 20%. The diagnosis can be made starting around 2 years of age. Prior to 2, it's really challenging to do it unless the symptoms are severe. And something to keep in mind, the less severe the symptoms, the more complex and challenging it is to diagnose somebody. So it's not unusual for me to diagnose someone at 8, 9, 10, or teen years with a very mild case or high functioning autism. These are just the overall general criteria that we use to make a diagnosis of autism. And I don't want to bore you with details, but just so you know, when we think about autism as a diagnostician, we have to remember that all 3 criteria within social communication, including social emotional reciprocity, which is that back and forth, nonverbal communication, and relationships, need to all 3 be impacted, as well as 2 within the quote unquote behavioral domain. And so that could be unusual movements or play activities or unusual interests or some sensory piece. When should somebody worry when they have a young child as far as potentially getting this evaluated? One is anytime there's language milestones, that is certainly one thing to consider. If a child is not responding to their name appropriately, if eye contact is not as good as what would be anticipated, anytime there's a loss of skills, somebody should be concerned about that. If there's any unusual repetitive hand or body movements, or there's atypical play with toys, rather than playing with the whole toy or using pretend skills, fixating on portions of the toy or doing things over and over. Delayed motor development has actually been found in studies to be one of the first signs of autism. And obviously, anytime that there's a sensory involvement, that this should be a consideration. Now, when you see these symptoms come up, what can also look like autism, but is not autism at all, right? And so this can be very confusing, because if you have an isolated language delay, or if you have ADHD, which obviously at the age of 2 is not diagnosed, but early on you start seeing some of these symptoms, or if a child is very anxious, some of these symptoms that these children experience look like autism, but it's not autism, right? And so these are some of the other things to think about when we see a child with these early symptoms. So how do we differentiate? How do we try to determine what is autism, what is not autism, right? Because when you first start seeing these symptoms, a parent will be very concerned. And the first thing that they think about is really the worst possible case scenario. Speak with the primary care provider. They can talk to you about what's expected from a developmental standpoint. They can start doing some screening tools in the office like the MChat. Anytime there's a language delay, no matter what the cause, a full hearing evaluation with an audiologist must be done. There needs to be some additional resources and evaluation that should be accessed depending on the age. Early intervention prior to the age of 3 in Pennsylvania intermediate unit, or in New Jersey, child study team evaluation for preschool setting starting at the age of 3. And then there are other additional community evaluations that can be done, such as community-based speech or occupational therapy, such as what's offered at Theraplay. There are other specialty evaluations that can be done, such as seeking developmental pediatricians, such as myself, or a psychologist that can look in more depth at autism-specific tests and diagnoses and diagnostic criteria. And so how is an official diagnosis made? At the end of the day, autism is purely a clinical diagnosis. We use all of these other tools to help us make that diagnosis, but we as diagnosticians need to use our clinical judgment to determine whether somebody falls on the spectrum of autism or not. And that's primarily done through a thorough history as well as observation and testing in the office. Initially, a screening tool can be very helpful. I also use the MChat in my office because it's just an additional tool that I use in addition to some of the other tools out there. There are questionnaires, such as the parent form of the CARS. There's also a clinician form of CARS that uses observational strategies to determine whether somebody falls on the spectrum. A structured interview is often done using the ADIR. That's usually done by a psychologist. And then there is the standardized kind of gold standard test for autism that is used. It's the ADOS. And this can be done by a physician such as myself, who specializes in autism, or a psychologist. And it is a structured in-office, in-person test that is done that lasts somewhere between 45 minutes and an hour. And there are different different things that are done during testing based on the child's age. So a test that's done on a 16-year-old is very different to one that's done with a toddler. And then, like I said, at the end of the day, it's really those clinical DSM-5 criteria that determine whether somebody is on the spectrum or not. There are a few occasions in which ADOS potentially could put somebody in a higher risk group for autism, and clinically I really strongly feel that they don't have it, and the things that put them in the higher risk group are more like inattention or anxiety symptoms. And then there are other times where I really feel strongly that somebody is on the spectrum, but they don't score so high on the ADOS because they have other skill sets in place that kind of mask some of those autism symptoms. But that's not common. Most of the time, the ADOS is really very much in line with what I find clinically. Now, as I said before, autism is very, very complex, as is the brain. The brain is really one of the most complex organs in the body. Now, as I said before, there are a lot of things that can mimic autism, but there's also a lot of things that can go along with autism, and that some of those things are medical. So constipation, sleep disorders, seizures, and then there's some behavioral aggression or ADHD type symptoms. There are some known genetic disorders that are associated with autism. And it's really important to keep all of these things in mind, because usually when I have a child with autism, it's usually a co-diagnosis with other things. And so if a new symptom comes up, like let's say a child is exhibiting new behavioral challenges, my knee-jerk reaction is not to automatically go to, oh, let's treat this with medication. My thought process is, well, this child is now in a much higher risk group for having a seizure disorder or a sleep disorder or something else, or constipation. We need to investigate this using another avenue. Maybe they're nonverbal or they are not able to communicate. And so we need to maybe look at the medical piece, or is there something else going on, rather than just using some strategies that we would use for a child who's not on the spectrum. As far as the treatment, it's very multimodal. There's not one aspect of treatment that is the isolated treatment modality for children on the spectrum. Some of these treatment modalities are obviously age and developmental specific. ABA is really the primary modality that's used to give structured instruction in regards to providing skills to help with social language, with play skills, with eye contact, and those kind of things. Early intervention, intermediate unit early on are ideal. Obviously, the school-based services, and also community services, as I had mentioned before. You know, it's not just speech and OT. Like I said, a lot of times these kids have gross motor challenges as well. There are social skills groups available in the community. If there are significant challenges in regards to language skills, they may benefit from augmentative communication. Feeding therapy can also be very helpful. This is a very common challenge for kids on the spectrum. Behavioral supports vary based on state. In the state of Pennsylvania, it is done through Medicaid, and under that subheading of Medicaid, wraparound service providers can provide behavioral services as well as ABA. In the state of New Jersey, Perform Care is the behavioral service provider. Obviously, counseling can help both in school and outside of school. And it's always really important to keep in mind that we don't want to over therapeutize and over medicalize this and educate. You know, there has to be a bigger picture, and a big part of that is community and involving kids, with whether they have a diagnosis of autism or not, in community activities. And there are many sporting activities or other activities in the community, whether they're religious or otherwise, that specifically target kids on the spectrum, or even having them be involved with typical peers can be very helpful as far as role modeling and that developing friendships and social engagement. Sometimes additional medical workup is warranted. As a developmental pediatrician, when I see a child and make an initial diagnosis of autism, I always recommend a genetics evaluation to see if this is something that's heritable and potentially could be something that could affect future siblings. Anytime, as I said before, there's a new behavior, a new concern, I always worry, is this a seizure? So maybe following up with a neurologist, or having gastroenterology and nutritionist involved if they're feeding issues. Anytime there's a new behavior, we always have to also think about the dental piece. And it's very important to find a good dentist that works well with kids on the spectrum and kids with special needs in general. If somebody's nonverbal and they have a cavity, it will look like a behavioral challenge. And so that's very, very important to keep in mind. And then sometimes we can do medication support. That's usually not first line. All of these other strategies are usually utilized first. But medication support is something that I use in the office, specifically to treat anxiety, impulsivities, attention span issues, sleep disorders, things like that. Seizures is not something that I treat in the office, but that's something that neurology would do. It's very important for those Pennsylvania families that once you get a diagnosis of autism, you must access medical assistance. This is not financial based, it is need based. And if you have an IEP, whether it's early intervention IU or through the school district, your child automatically qualifies for medical assistance, but you need to apply for that service. This is the website through the state of Pennsylvania where you access that. The process is time consuming. So I recommend that as soon as that diagnosis is made, that you reach out for service supports. Now, medical assistance is the provider for wraparound and in-home ABA. Or if you need service supports, if the child is in private preschool or private school or prior to the age of 3, again, this is who you access to get that ABA support. There are other wonderful organizations that provide many resources to families as well as advocacy, including Autism Speaks, Autism New Jersey, there's the PA Autism Network, and Autism Society, which is a national organization. And then this is just contact information for my practice. It's located in Yardley, Pennsylvania, in Bucks County. And I'm going to just give the platform over to my colleagues here. Hold on one second. I'm having a hard time finding my stop share. Here we go. Excellent.
Thank you, Dr. Willems. That was a ton of wonderful, wonderful information. As she spoke about, a lot of with a child with autism is embedded in the language. And once we find a way for that child to communicate, whether it's verbal or another option as well, it helps that child communicate what's happening. And then we can get at some of those other underlying things that may be occurring with the child that may be masked as a behavior when really it's not a behavior. So that's important. That's our job as speech language pathologists. Oftentimes, because that language delay is such a common sign of autism, we often see a child even before they have the diagnosis of autism. When we look at a child, we are looking at what they need to work on from a communication standpoint, and we will often refer to Dr. Willems to get them connected with additional resources as well, if we think that's the route that we're going to take as well. We will also communicate with the PCP as well, if that's something we would like you to pursue down the road. But when a child comes in and they're not using any language, if they're in that younger age, that 2 to 3 year old age, we'll try to work with them to see if we can get some verbal language. But again, we want them to have the ability to communicate successfully so that they can say what they want to eat, what they want to drink, what they want to play with, or how they're feeling, or if they're hurt, or anything they're feeling. If verbal doesn't come naturally, I always say a child will use what comes naturally to them and what comes easiest for them. Us as adults, we're the same way. We do what's easiest for us. So if verbal is going to be easiest for that child in the moment, they're going to use the verbal. But if not, we need to give them another way to communicate. And that's when we look at augmentative and alternative communication systems. It could be something high tech, as we call, which is a device where they press the button and it speaks for them, or it could be something low tech, something simple as what we call a core language board, or a picture exchange communication system, where they hand over a picture and then the picture has on it what that they want or what they're feeling. So we're going to look for different options. Sometimes we need to use these options a little bit long term, and sometimes they're short term, and we see some of that verbal language come along. We as speech therapists too will always accept what the child gives us. If they're going to communicate verbally, that's what we want long term. And so we're going to accept that verbal communication, but also teach you as parents and the other providers in the child's life so that they can also use the communication system that we set up for the child as well. Once they get older as well, we might work with some of that social language, because there is such that pragmatic, that social piece. As Dr. Willems was saying, that communication exchange is so important. So we might work with them to teach them, what is the basis of a conversation? How does that look? Is this socially appropriate to do in this situation? And we'll work with them through different scenarios that they may have and teach them the skills so that they can be successful with interacting with their peers and other adults in their life as well. And then we also can work with children who have the feeding challenges. Some children, as Bianca will talk about, can be very picky with their eating. Sometimes that often goes along with children who are on the autism spectrum. As speech language pathologists, we want to make sure we're ruling out anything that is happening from an oral motor standpoint. So our goal is to make sure when that child does get the food in the mouth, that they are successful with eating that food. They can chew it, they can swallow it safely. If a child is limited in their food choices and then they start to put something in their mouth that they haven't experienced before, we might have to teach them how to chew it. We might have to help them learn how to manipulate it around the mouth. Our mouth is made out of muscles. So just like you would work an arm muscle or a leg muscle, if that were not in use, it's the same way with our mouth. We have to teach them how to reuse their mouth to chew, swallow safely and successfully so that they can get the proper nutrition, which will then help in return other areas of their quality of life as well. So Bianca, I don't know if you want to talk a little bit about how you as an OT work into feeding as well.
Absolutely. So, yep, I'm going to talk about occupational therapy and how OT treats kids with autism. So, just in general, to start, I just want to kind of touch on the fact that we know that autism affects each child differently, and it can present in a very unique way per the child. So as OTs, that means that our therapy might also look different across every child. So it's up to us to perform a evaluation and find out what each child's strengths and weaknesses are, and use a very child-centered approach to our occupational therapy. So as an OT, what we look at the areas of occupation that are being affected and how these areas are being affected. So for example, in children with autism, play is an area that can be challenging for them because of that social engagement piece. Fine motor and visual motor skills might be challenging. ADLs, which are activities of daily living. So that includes anything like getting dressed, bathing, brushing your teeth, brushing your hair, sleeping, eating. Sometimes those daily living skills can be challenging, as well as instrumental activities of daily living. So these are called IADLs. It's more of an OT term, but this includes things like meal prep, chores, typing, using a telephone, anything like that. So first, I just want to kind of talk about sensory processing, because that is such a big area for kids with autism. Sensory processing difficulties can be really prevalent, and they can present in a lot of different ways. So sensory processing, just in general, a pretty brief definition is just how the brain receives, organizes, and filters sensory input from the environment. So we're always constantly receiving sensory input through all of our different sensory systems, and filtering out the unwanted sensory input. So sometimes kids with autism have trouble filtering out the unwanted sensory input. So for example, a child might be sensory hypo-responsive. So that means they are hyper-responsive, which means that they they might avoid sensory stimuli. So for example, in loud, busy environments, they might be covering their eyes, covering their ears because of that auditory stimuli. They might even avoid movement, or maybe when they're eating, they might avoid certain textures. For a kiddo who's sensory hypo-responsive or under-responsive, these are the kids that are unaware of when their clothing is disheveled. They might go to the playground and they can swing for what seems like hours on end, or they spin for a long time because they're under responsive to that sensory input. It takes a lot of input in order for them to feel all of that sensory stimuli. And then the last one are sensory cravers. So these are the kids that really crave and want a lot of sensory input. A lot of times children with autism are sensory cravers. They seek jumping, running, crashing. They might speak loudly or use a loud tone of voice. Sometimes they might use a lot of sounds during the day to try and communicate. A lot of times they might even lick, mouth, or bite non-food items. So they're looking for sensory input in a wide variety of ways. So just in general, a lot of times what happens with kids with autism is they're constantly trying to process and filter out different sensory input, and it can be really challenging. And what the result is it looks like a disruptive behavior. So a child might not be able to sit in a chair for a long time, or in the classroom, they might not be able to stay in line with their peers. Maybe in social engagements, there's maybe we feel the need to push other kids or elope and run. So it might look like a disruptive behavior, but really what's happening is that their sensory system is just a little out of whack. And as OTs, what we can do is help regulate that sensory system. So a lot of times we'll provide different sensory strategies, or we might even recommend a sensory diet to assist with this more efficient sensory processing. So a sensory diet might include adaptations like cutting tags out of clothing so that they can tolerate wearing different clothing. It might look like using noise canceling headphones. It might include something like recommending a weighted vest or a weighted blanket. So just in general, that sensory processing piece is really huge for kids with autism, and that's definitely a big area where OTs can help out with. And then I also just want to talk about play skills as well. So that's another big area where OTs can kind of jump in and help out. So for all kids, play is the #1 occupation. A lot of times kids with autism who come in for an OT evaluation, a big part of that evaluation is talking about those play skills. So sometimes a parent might say that their child prefers to just play by themselves, or maybe they prefer to tap their toys together repeatedly, or line up their toys, line up their cars. So what we do as OTs is we can find out kind of how they play, and then try and figure out ways to expand that play so that they are socially interacting with other peers. They're building skills like becoming more flexible in play and assisting maybe with transitions from one place to another. Sometimes that can be really challenging for kids with autism, so we can assist with that as well. And then we also, kind of like I said before, we work on those ADLs and IADLs, so those daily living skills. Really important to note that sometimes these skills can be challenging because we have deficits in other areas. So children with autism, motor planning is something that can be challenging. So for example, when you think about getting dressed in the morning, when you put on a shirt, you have to sequence through all of those steps in order to complete that motor planning process of putting on a t-shirt. So sometimes kiddos with autism, that can be challenging. So we might use something like chaining, where I might help put the shirt on over their head, then they can finish the task of pushing their arms through. Or maybe if we're doing toothbrushing, maybe we'll take pictures of each step and use more of like a visual schedule to sequence through the steps of toothbrushing. So that's one way that we can help with that. We can also help with skills like bilateral coordination to maybe complete something like shoe tying. Pressure grading is another big one. Sometimes kids with autism, it's tough for them to figure out how to grade their pressure. So even when we're eating, you have to know how to hold a spoon properly so that you can maybe scoop cereal or pudding, bring it to your mouth without spilling. Maybe when you're brushing your teeth, like using the right amount of toothpaste to put on the toothbrush. Those are all things that you need that appropriate pressure grading that can be challenging with kids with autism. And then, like I said before, that sensory processing piece is really big and can definitely impact those ADLs and IEDLs. So something like brushing your hair, getting a haircut, brushing your teeth, those all present a lot of different sensory stimuli. So we help kind of work through those challenges, or maybe adapt some of those tasks to make it a lot easier for these kiddos. And then we also work on school-related tasks, something like working on fine motor and visual motor skills to help out with handwriting, or cutting skills like using scissors, anything that can help them perform a little bit better in the classroom so that they are keeping up with similar age peers. And then also we work on the feeding therapy as well. So just to touch on that a little bit. So for OT, for feeding therapy, we look at it through more of that sensory lens. So we try and figure out, are there certain textures that we're only eating? Do we only like crunchy foods, or are we avoiding more of those messy texture foods? Are we avoiding mixed textures? So we look at feeding therapy through that lens and try and just little by little kind of expose them to different textures so that they are feeling more and more comfortable to eat more foods. And then hopefully that'll improve things like meal times or participation in lunch at school, and overall improve that overall nutrition, really. So that's kind of a brief overview for what OT can do for autism.
I was going to say also too, co-treats are so important, and working together with the occupational therapist and the speech therapist together, as Bianca was talking about, the sensory regulation and the sensory diet. If we're trying to teach the child language and how to use the language, we need them to be regulated. We need them to be able to concentrate on what we're saying and really focus. And if they're not regulated sensory wise, we need our OTs to kind of help the children get to that point, and also teach us so that we can implement some of those skills as well, and teach the parents so that we can carry that over and they can learn successfully the language. Also too, as she was talking about ADLs during a co-treat, we also need to evaluate, does the child truly understand the receptive language? So receptive language is the understanding of language. If they're presenting a direction for the ADL to be followed, does a child understand that language that is being used? And we might need to alter the directions. And so we work with the occupational therapist to say, hey, these are the concepts that the child does understand, or these are the concepts we're working on teaching. And so let's try to either avoid these concepts right now, or look, we're at the point where they understand them. Let's try to use them to get them to successfully follow this ADL activity. So co-treats and working closely with our occupational therapists is so important to help a child to be successful as well.
That was one of the notes I had written down for myself as well, is that is one of the pieces of Theraplay that my patients benefit from significantly, is the co-treatment modality. They find it very, very helpful to have more than one specialty involved in the care at one time. And that is something that can be done because you have multiple providers at each facility. And I wanted to touch on something that Bianca had said as well, which I did not mention when I spoke before, but it's so important. And that even though one child has a diagnosis of autism and another child may also have a diagnosis of autism, those are completely different people. And we always, no matter what a diagnosis is, we always have to look at them as individuals, because they present so differently based on their innate personality and their strengths and their challenges. And so, a diagnosis is really just a language that we use to provide the service supports that a child needs, whether it be in the community or through school. But it's really just language. It doesn't change who that person is from before the diagnosis. It's really just a tool that we use to help the child and the family navigate all of the opportunities that child may have. But just the diagnosis in and of itself does not define the child. So I just want to mention that. So thank you for mentioning that, Bianca. I did not touch on that.
That's a great point. So true. Jason, I don't know if anybody has any questions, comments from the audience for us.
No, not at the moment. We don't have any questions. I would invite anybody that is tuned in at the moment to go ahead and write in some questions to Facebook.
Now, one of the things that you had mentioned before, Bianca, was about the elopement piece. Now, that's something that, especially for those children who are more active, that I speak with families about in regards to safeguarding the home and putting alarms in and just making sure that everything is tucked away and they use all of the safety devices in the home. But elopement is a challenge for some of my families and kiddos. And so there are multiple resources as far as tracking devices and things like that. And there's so many available on the market. Is this something that you guys work with the families with as well as far as accessing that? I know that there are some local police and sheriff departments that offer that as an option. There are some families that go through insurance and they're able to get it covered that way. Or there's some that just pay for it privately and just have an app on their phone where they're able to track the kids if there's a concern.
I personally have not helped any family navigate through that situation, but it is certainly something, and Bianca, you can add to it too, that we talk about with the families to say, hey, what's going on at home? What does that look like? What are some challenges at home still going on? And then we'll connect them back to you or whoever. Will do our best to get them the resources that they do have available. Bianca, I don't know if you've had any direct experience with that.
Not directly. I would say just in general with elopement. I mean, we see it here when we're treating some of our kiddos, but I would say in sessions, we try to just give the children the tools that they need to maybe a speech therapist will work with them to request a break. So if they're sitting at the table and all of a sudden you can tell they're really getting overloaded, their sensory system is becoming overstimulated, and it seems like they're about to get up and run, maybe providing some sort of visual, like to communicate that they need a break. Or maybe something where, you know, first we're going to sit at the table and then we can go get some sensory input on a swing, or sensory input through an obstacle course, something like that. Tools and strategies, those are some tools and strategies that we use in session that can help decrease some of those elopement behaviors, and then teach kids the tools in order to avoid running away from certain tasks. But obviously, if it's something that it is really unsafe and it's happening in more like public situations, I think, like you said, some of those recommendations, like talking to the police department and things like that, is something that can be really helpful.
I agree, especially for my older patients with autism. I do recommend that the families meet with the police department and just develop a positive relationship for the child with the police, so that when they see a police car, or they see the lights or the signs, or they see an officer in uniform, that they don't fear, that they know that's somebody to go to rather than run away from. So I think that's a really good point. And Courtney, I just wanted to ask you, because I think there's a very common misperception that if you introduce augmentative communication, or just any form of alternative communication, whether it's a core language board or sign language, that will delay verbal language. Now, every study I've ever read and speech therapists that I've talked to who is well versed in this area has said, no, that's not the case. If anything, it encourages verbal language, because you're actually increasing communication.
Teaching the concept of
give alternate means of communicating. It actually improves somebody's confidence, decreases language anxiety. So I didn't know if we wanted to talk about that a little bit, because I think that's very common concern.
Yes, it's totally true. There's a lot of research out there that shows that is a myth. It does not prevent the verbal production of language for that child. I always say a child will do what is easiest for them in the moment. And if they have that ability to complete verbal, it is much easier. Think about even a picture communication. If it is a picture that they have to hand over to make a request or even point to it, they might have to put their toy down and then look at the picture, scan the picture, and point to it. And if that verbal production is going to be easiest for them in the moment, that is going to be easier for them to produce. Just like Dr. Willems said, it does improve their confidence. They're learning the concept of, I do something, I communicate, and I can get what I want. And that has so much power. Like, hey, I just controlled that situation about what occurred. And so if it is by sign language, if it is by pictures, they're learning that concept, and they're learning what communication is. And they learn that communication is that back and forth, and it's not just a one-way street where you listen. I have to say something, or I have to do something, and then I can get it in return. They see the action that happens, and that naturally is a reinforcement for them. You know, I said the word cookie and I got a cookie. That's fantastic. You know, there's definitely, I always talk to parents too, that just because a child is learning that language, it's okay to say no, right? If they're asking for a cookie, not at an appropriate time, it's okay to say no, but you're at least responding to them, and they're getting some type of response from you. And they're learning that back and forth exchange of communication and what that truly is. So I have seen kids who, start with picture exchange, and we start to see early on that language starts to explode, or they might supplement. That is augmentative and alternative. It's truly to supplement their communication that they have. If they can say that word cookie verbally, then great, accept that word cookie. But maybe that other word of bike, when they want to go outside and ride their bike, doesn't come easily to them verbally. So they're going to use the picture communication to express that they want to go out for a bike. But they can pair those two together from a verbal standpoint in pictures, or verbal standpoint in signs, to get what they want, or to express what they're thinking and feeling. And that just itself is naturally rewarding for them. And so it just encourages any type of communication for them. So that's a great point.
I do want to mention also that Theraplay is an early intervention provider, and
Mhm.
I don't know that a lot of people know that in the state of Pennsylvania. You know, there are many providers who are not seeing clients in
As a
person,
person.
whether they're state or you know, school funded or whatever, or even private. But Theraplay back in May opened their doors back up
Yeah.
to patients in person. So I know
Yes.
that my patients especially have really benefited from that.
Mhm. Yeah, we can see kids from birth to 21. So just give our centers a call. We'll communicate back to the PCP or Dr. Willems, a developmental pediatrician as well, to get a prescription on file, and then we can continue seeing you for services. We do accept most of the major insurances. We do accept Keystone First as well, but just give one of our centers a call and we can get you started with an evaluation.
Well, while we didn't have any audience questions, I just want to thank all of you for this was a really, really great Facebook Live. I really enjoyed it. The video of this will appear on our Facebook immediately afterwards. So please feel free to share far and wide. And if you do have any questions, go ahead and pop them in the comment section and we will get back to you on them. So again, want to thank Dr. Willems and everybody for joining us on this Facebook Live today.
Thank you.
Thank you, Jason. Thank you, Bianca and Courtney. This
Thank
was
you,
great.
Dr. Williams. This is fantastic.
Yes.
So great to see you again.
Yes.
Awesome.